Hi, welcome everybody. We are thrilled to have you joining us today for our Cancer Grace Tour de Force mini tumor board that we have here. My name is Dr. Isabel Preeshagul. I'm a thoracic medical oncologist at Memorial Sloan Kettering, and I am joined by two incredible thoracic oncologists. We will have them each introduce themselves, and then we will go on to our case-based discussions. We are going to be talking about two cases today, one in the resectable setting and one in the metastatic setting. And we look forward to taking you through.
Hi, I'm Christine Garcia. I'm a thoracic medical oncologist and assistant professor of medicine at Cornell.
Hi there, I'm Debbie Doroshow. I am also a thoracic oncologist and associate professor of medicine at Mount Sinai. And let's get started with our first case. All right. So this case is going to take us through a patient with resectable or operable lung cancer. So Ms. Turner is a 64-year-old third grade teacher who has smoked one pack of cigarettes a day for 30 years and has type 2 diabetes. She's had an increased cough for 3 months, and she was treated twice with antibiotics and steroids, but didn't feel any better. She had a chest x-ray which showed a large mass at the bottom of her left lung and some concerning enlarged mediastinal or central lymph nodes. A CT scan of her chest showed an irregularly shaped 4-centimeter mass in the lower left lung, represented here by the large pink dot, with enlarged lymph nodes in the mediastinal and left hilar or more peripheral regions. She also had an MRI brain, which showed no evidence of metastatic cancer. This is an example of a PET scan that might look like hers. We have a handy arrow here pointing to her primary cancer, which you can see lights up quite a bit as it's very hypermetabolic, growing faster than other parts of her body. So based on what we know just from her imaging, we would call this a T2B N2A or stage 3A cancer. She underwent a bronchoscopy with biopsies of both the mass and several areas of lymph nodes. And the pathologist found lung adenocarcinoma in the primary 4-centimeter mass, as well as in both mediastinal and left hilar lymph nodes. Next generation genomic sequencing was sent out right away and showed no alterations in EGFR or ALK. Tumor testing showed that 40% of her tumor cells expressed PD-L1. So what do we do next? We have lots of options. There are several options that include surgery. We can give chemotherapy and immunotherapy after surgery, or what we call adjuvant treatment, chemotherapy and immunotherapy before surgery, or a neoadjuvant approach, or chemotherapy and immunotherapy before surgery, plus additional immunotherapy after surgery, which we'll refer to as a perioperative approach. There's also a non-surgical option. She could have concurrent chemotherapy and radiation, followed by 1 year of immunotherapy. And of course, we're always thinking about any available clinical trials at every single point of a patient's journey with cancer. So we have lots of options. I want to certainly just list here all of the medications that are available in all of these surgical options. You can see that there are many in each option. These medicines are very similar. The results we've seen are very similar. And I want to ask my colleagues to chime in. What do we do next?
So I think that you presented the case very beautifully. And maybe 5 years ago, we really didn't have many options for patients just like this. And I think, number one, we always have to think about what's important to the patient and what works for their lifestyle. And I guess what's in their best interest. Something that we always want to make sure when we're making this decision, whether we expose them to chemotherapy and immunotherapy before or chemotherapy and immunotherapy after, or the perioperative or sandwich approach, is just to make sure that they don't have any targetable driver alterations like EGFR or ALK. So that's one thing that helps make my decision. But given some of the data that was presented more recently about the benefits of giving patients just like this neoadjuvant or induction therapy, I think it's a nice way to see prehabilitation, so we can kind of see how is this tumor going to respond to treatment, right? We can also get a nice in vivo and in vitro take a look and see what's going on inside the tumor when the tumor is taken out after they get exposed to treatment. And their patients in this setting are often more fit, right? They're not just coming right out of the OR. They are, newly diagnosed, and they are not dealing with wound healing and being in the hospital. I think they're likely to better tolerate treatment. So I tend to lean to that.
I think this is a really you made some really great points, and really looking at the patient in front of you and what you think that they're able to tolerate. I think it's helpful to think about timing, the potential risk of being on treatments for longer periods of time, the risk of cumulative toxicity. So these are a lot of different patient factors that we have to consider, in addition to all of our, thankfully, our increasing number of options that we have.
Those were really interesting and important points. I think one thing that I like to think about myself is the fact that lung cancer surgery can be a really big operation, requiring a lot of recovery time. And sometimes it can be hard to start the adjuvant treatment as soon as we would like after surgery. And people are just more worn out because they've been through a big operation. So if I can give treatment prior to surgery, both for that reason and for the reason, as Dr. Preeshagul said, to find out how the treatment is working on the cancer, I do like to do that. So I just briefly wanted to mention that we have not determined whether all of these medicines improve survival among people who get them. What most of our studies have looked at is event-free survival, which is a fancy way of saying how did this medication help someone live longer without their cancer coming back? And really looking at prolonging that time to the cancer coming back if it does come back. And that's really important, but we also really care about making sure patients can live longer. So I just wanted to note here that so far, we really have two regimens where we know survival is improved, and one regimen in the after surgery or adjuvant setting where there's some possible data suggesting improvement in survival for patients with high PD-L1 expression. That doesn't mean that the other regimens are bad. In many cases, we're just waiting for that data to read out and it's immature. But we'll look forward to seeing what those studies show us. And so, what do we do next? So, Ms. Turner tells you, and this is a really a good example of how personalizing treatment to someone's needs and someone's schedule can be helpful. She tells you she's really minimal vacation time this summer. She's also teaching in summer school, and she wants to get treatment and surgery over with as soon as possible. And I've had multiple patients who felt this way before. So you discuss the options, and based on that preference, you guys decide to choose a neoadjuvant only approach using chemotherapy and nivolumab based on the Checkmate 816 trial. And just to review what this study did, essentially patients whose cancer could be removed in a surgical fashion were randomized to either receive 3 cycles of chemotherapy before surgery or 3 cycles of chemotherapy with the PD-1 inhibitor nivolumab. And then they went to surgery, and we were looking to see, again, this idea of event-free survival. Certainly, the patients who got nivolumab had improved event-free survival, and you can see that the orange curve representing the probability of a patient being alive and without recurrent cancer is certainly higher than the teal curve below it the entire way through. So let's talk about how it went for her. Luckily, she tolerated this treatment very well. The good news is that we're only giving 3 cycles of treatment as opposed to some regimens that require 4 doses or cycles of chemotherapy. She did have some hypothyroidism related to the nivolumab that was treated with levothyroxine. And after the surgery, the pathology report comes back, and the cancer is a 3.1 centimeter adenocarcinoma, so smaller than it was before, with 30% viable tumor and 70% necrosis or dead tissue. And they only see cancer in one hilar lymph node. Remember, before it was also present in one mediastinal lymph node. So we would call this pathological staging T2BN1 or stage 2B. So the good news is that the preoperative treatment shrank the cancer, but it didn't disappear completely. So the question is, what do we do now? And I want to again bring my colleagues on to talk about what they might do.
I'm very pleased to see that she was able to tolerate treatment well and that the treatment did downstage her, which is nice in that sense. But something that helps us determine if someone needs more treatment on the back end of their surgery or perioperative, meaning treatment before or treatment after, is the percentage of how much of the tumor is alive after those 3 cycles of chemotherapy and immunotherapy. So as you had told us, it looks like there's still 30% viable tumor, right? So the measurements that we use to determine if someone has responded to treatment, or a measurement you could say, is complete pathologic response, which means there is no viable tumor at all. All of the tumor that's taken out was dead, or what we call major pathologic response, which means that there's only 10% viable tumor. So unfortunately, Ms. Turner still has 30% viable tumor. So she did not achieve a complete pathologic response or a major pathologic response. So that aspect in itself meets some criteria to push me towards perhaps wanting to offer more treatment to somebody. And then in addition to that, something else that might help guide my decision is your baseline PDL1 expression. I know that there was a subset analysis of patients from the Checkmate 77T study that looked at who really benefited more. And it really was those patients that got chemotherapy and immunotherapy and went for surgery. It was those patients that had active viable disease and a high PDL1. So so I think it's worth a discussion for her. The only thing that might give me pause and make sure that I'm aware of, committing someone to treatment ongoing for a year after, is also the fact that she developed some immunotherapy toxicity with hypothyroidism. So while it's listed as mild and controlled on levothyroxine, it's still a sequela of treatment. And the more immunotherapy you get exposed to, the greater the risk of developing more immunotherapy related side effects. So this isn't a decision to be made lightly, but I think she is someone that I would consider having the discussion.
I completely agree. Really thoughtful approach in that this is a patient that I would really spend some time to review some of the options, since to your point that while the hypothyroidism was mild, we don't know if she may have more worsening of her toxicities or develop new toxicities if we're committing her to a year on immunotherapy. But I agree with the fact that she did not achieve PR or a major pathological response is a reason that I would consider giving extra immunotherapy to this patient as well.
Thank you guys so much. So let's take a look at some of the data so far. And we're going to do something that we're not usually allowed to do, but that we always do anyway, which is to compare results from different trials. And this actually is a really helpful comparison. So first, they looked at the results of Checkmate 816, which is the regimen that Ms. Turner got, which is a combination of nivolumab and chemotherapy before surgery. They put that up against the results of Checkmate 77T, which is essentially basically the same regimen, chemotherapy and nivolumab before surgery, but then patients get additional nivolumab after surgery. And what they found when they looked at all of the patients, oops, I think we went ahead for a sec. What they found when they looked at all of the patients was that overall, the people who got additional immunotherapy after surgery seemed to have a better event-free survival. But Is it possible to figure out which group of patients is really benefiting? Because as my colleagues just mentioned, our treatments can cause side effects, and the longer you're on those immunotherapies, the more side effects can present themselves. So is it possible to figure out certain groups of people who really might need that extra post-operative immunotherapy? And so this is a really nice comparison, essentially, of patients on the two trials. Remember, the sandwich approach where they got extra nivolumab is in the teal, and the neoadjuvant approach is in the gray. So on the left, you can see that for patients who had a pathologic complete response, there was no viable cancer, no living cancer when they had their surgical resection. Really, there was no difference in event-free survival between the people who got nivolumab only before surgery and the ones who got it both before and after. But if we look on the right, there is a nice separation in the curves here. And it does suggest that although the 95% confidence interval crosses one, so we can't say it's statistically significant, but we do find here a suggestion that perhaps patients who do not achieve a pathologic complete response might be some of those patients who benefit from adding additional immunotherapy after surgery. Lastly, they compared groups of patients based on their PD-L1 expression. So if we look on the left, for patients with a PD-L1 of less than 1% or negative PD-L1, the patients who got nivolumab before and after surgery clearly did better, and this was a statistically significant result. Again, doing something non-traditional, comparing the results of two trials directly. As you can see on the right, there's really not much difference between the two curves for patients whose cancer expressed PD-L1. So again, this suggests that there's a second group of people, people with PD-L1 negative cancers, who might benefit specifically from adding additional immunotherapy after surgery. And so, in summary, for this topic, immunotherapy before and after cancer compared to neoadjuvant immunotherapy alone tentatively seems to benefit people who don't have a pathologic complete response and those whose cancers are negative for PD-L1. More treatment, as my colleagues have mentioned, does certainly pose the risk of more toxicity, and that needs to be part of your discussion with all people that you see in your clinic, and for patients who are listening with your doctor. It's unpredictable, unfortunately. I wish we knew in advance who might develop what side effects, but we don't. Immunotherapy is also not the right choice for some people. So, as Dr. Preeshagul mentioned earlier, it's very important to get next generation sequencing because people who have cancers that have mutations or alterations in certain genes like EGFR, ALK, ROS1, and potentially several additional genes likely don't benefit from immunotherapy. They certainly can have harm from it in the setting of having side effects. There are also people with, for example, autoimmune diseases that are severe, people with interstitial lung diseases, especially severe ILD, and other conditions that might make immunotherapy unsafe. All right, and I will now turn it over to Dr. Garcia.